So now what we're going to do is we're going to talk about the circuit itself. I'm going to hide the portion of where the numbers are because I know a lot of physicians like to focus on the numbers, but the numbers we'll get to. More importantly, it's important to know where the blood is coming from, where it's going, where that pressure is negative and where the pressure is positive, and why that makes a difference. So what you see here is a primed Ecmo circuit. And it's still connected to its prime bag. And the reason why I have it connected to my prime bag is because I want to be able to circulate and show you numbers. In perfusion, we like to keep things as simple as possible. So we usually color code things, okay? So if we make pretend this is the right atrium, the blue tubing, the writing on this tubing is blue, there's blue tape on it, represents deoxygenated venous blood. So we're going to be basically sucking blood out of the right atrium. It's going to go down this tubing, and it's going to go into the center of this pump. And I always make a crude analogy of like if you ever gone on Gravitron or any of those rides at the fair, it's all centrifugal force. It spins really fast, the bottom drops out because negative pressure gets sucked to the wall, right? It's the same thing with this pump. The pump spins really fast, creates negative pressure. That negative pressure is connected to the right atrium. We suck that blood out, goes into the center of the pump, and then there's fins inside that pump where it's spinning really fast. And when the blood hits it, the pressure on the outside part of this pump is positive and it propels that blood forward. All right. So now we have positive pressure, still venous deoxygenated blood going into the front of the oxygenator here. It goes through the oxygenator, comes out highly oxygenated and ventilated. And we'll go over how that happens momentarily. And then comes back out and then goes back into either a vein if it's VV or an artery if it's VO. Right. So let's talk about where the pressure is negative and where it's positive. Okay, and why that's important. So we already said that the centrifugal pump in the center is causing negative pressure to suck blood out of the right atrium. So essentially everything from the right atrium down this blue tubing to the center is all negative pressure. And you'll notice that we have a pigtail on this part of the circuit. If I was to open this stopcock, that negative pressure that's spinning would suck air right into the pump, okay? And if it's enough air, it's going to stop flow. It will never stop the pump from spinning because I control that, but centrifugal pumps need a preload in order to flow. So if I replace the preload of fluid with air, the pump still spins, but there's an airlock and no forward flow will happen with the blood. Once everything gets past the pump, it's all positive pressure. So if you were to make a mistake or something happened and you opened up the stopcock, you're just going to make a mess. Another reason why it's very important to know the difference between the positive and negative is when you come off Ecmo, you have to come off emergently or routinely. I would say 95% of the time you want to clamp the positive side. If I clamp the venous side, or the drain side first with all that negative pressure, and I'm spinning really fast, and there's not a whole lot of volume in the patient, I can cavitate and pull air in a solution. You ever take a syringe full of fluid and pull back in really hard and you get bubbles? It's the same concept. It's that you're just, by clamping that drain inside, you're increasing that negative pressure very quickly in a small volume of space, and you have the possibility of pulling air. The only time I would ever say you would clamp the drain inside first is if the drainage cannula came out. Because if the drainage cannula came out, you're still spinning with this pump, and now you're sucking atmosphere air into your pump. That's the only time I would ever clamp drain inside first. If you have air in your circuit, if it's on the drainage side and it's a little bit of air, it shouldn't be an issue. The centrifugal pump will pump it forward and it will go into the oxygenator, and the oxygenator will basically handle it. If you get a big air bolus like we talked about before, and it basically stops your flow, then you have to come off Ecmo, call it perfusion. If you have air on the arterial side, that is much more dangerous, and you have to come off. Because if you don't come off, that air, especially if you're on VA, is going to go systemic. If you have air on the return side or past the oxygenator, you always want to clamp in front of the air, right? Because if this is where my air is, I want to clamp in front of it. Now I'm off, and I can walk that air back to the oxygenator, and I can remove that air. All right. So now let's talk a little bit about how the oxygenator actually works. So in anesthesia, you guys are used to like blenders on a ventilator, it goes from room air all the way up to 100%. If you put someone on a nasal cannula, high flow or something, same thing. You're just basically being able to take, you take 100% oxygen with medical grade air, and then you can mix it. So this blender here, it's got 2 flow meters and then a dial for your FiO2. And the dial goes from room air, 21%, all the way up to 100%. I do a quick calculation, and if I can do the calculations, it's pretty simple. So whatever my FiO2 is on my blender, I multiply it by 5, and that gives me roughly what the PO2 is inside the oxygenator. So if I'm at 100%, 100 times 5 is 500. That will be what the PO2 is inside the oxygenator. Venous blood, if it's normal, has a PO2 of about 40, right? So you have PO2 of 40 going in, 500 inside of it. So it creates a huge pressure gradient. And gases always go from high to low. So that 500 of partial pressure of oxygen forces it into that low 40 PO2. So when it comes out and mixes a little bit, your PO2 might be 450, but much higher than a normal PO2, which is like 80 to 100. So that's how we oxygenate the blood. But we know that our lungs don't just oxygenate, they also ventilate. The way we control ventilation or CO2 clearance is by how fast we put the oxygen into the oxygenator. But what we don't want to do is confuse people. We don't call the flow of oxygen flow, because whenever we talk about flow in Ecmo, we're talking about blood flow. So we don't want to confuse people with 2 different flows. So the flow of oxygen is just called sweep. All right, so whenever you hear someone is on 3 a sweep, that just means they're on 3 liters per minute of oxygen. What we can do is, if you think your sweep is minute ventilation, if your CO2 is high, you increase your sweep to blow off more CO2. If your CO2 is low, you decrease your sweep to retain more CO2. So you manage it just like you would minute ventilation. The way it really works inside here, the way it looks like, is this is a PMP oxygenator. And so the oxygen from the flow meters comes through the oxygen tubing and goes through these PMP hollow fibers. Blood that runs over it, and that basically creates like the alveolar capillary membrane. And that's where you have that pressure gradient of the PO2 being super high inside the tubes and low in the blood that's going into it. And the gas exchange is high to low. Twice a day, we come through and we check the whole entire Ecmo circuit. In the morning, basically, we'll check the pre and post gas to make sure that the oxygen is working, making sure that the PO2 going into it is appropriately for venous, and that depending on what FiO2 we're on, that the gas exchange is roughly 4 or 5 times that. In addition to doing that, since these hollow fibers are oftentimes connected to a water source to maintain temperature, there can be condensation that builds up in those hollow fiber tubes. And you can think of that as like artificial, like pulmonary edema. So the way that we get rid of our artificial pulmonary edema is like 2 or 3 times a day, we'll increase the sweep, which will increase the flow of that oxygen through those fibers, and it'll blow that condensation out. And you'll actually see it drip out of the exhaust here. The other thing that the oxygenator does, so it oxygenates, it ventilates, and it also maintains blood temperature. We can connect the water source to it, and inside the oxygenator, the blood runs over a heat exchanger, and we put water through the heat exchanger at a certain temperature. So if we want to cool the patient because we want to lower the metabolic demand, we can set the water temperature to, let's just say, 34. So the normal temperature of the patient might be 36 or 37, and that warm blood that's running over the cold water loses heat to the cold water, and you cool the patient. And then if you want to warm them back up, you do the opposite. You make the water in the heat exchanger warmer than the blood, and then the warm water loses heat to the colder blood, and you warm up the patient. Let's talk a little bit about what the physicians really focus on, and that's the numbers. Okay? So the only thing that we can control on the console is how fast the pump is spinning. Okay? The faster the pump spins, the more flow you get. But there is a point of diminishing returns. Just like with PEEP, right? PEEP is good for oxidation until you make the alveoli so big that they start compressing the right atrium, and you can get actually reducing preload, and your actual oxygenation can get worse. Same thing with RPMs. At some point, you're spinning too fast for how much volume you have. You're going to create too much negative pressure, and you're actually going to lose flow. But theoretically, as you go up with RPMs, the more flow you get. Come down in RPMs, the less flow you get. So let's just say we're spinning at 3,000 RPMs. My flow is 2.65, and then, all of a sudden, no one puts a clamp on here. I'm just going to do this to mimic what you would see. you can see I didn't touch my RPMs, but my flow went down almost by a third. So we need to figure out, am I having a drainage issue or am I having an afterload issue going back into the patient? The first thing I would look at is that my pressures didn't go higher, right? They went lower, if anything. So that lets me know that I did test my RPMs, my flow went down, my pressures didn't go higher, so it's a drainage issue. There's three major causes of drainage issues that all kind of present the same, but are caused by different issues. So I call them different buckets. My first bucket, when I think there's a drainage issue, is that the patient has enough volume, but there's something mechanically wrong with the circuit that's preventing that volume from getting into my circuit, okay? And that could be just something as simple as the nurses or I turn the patient, and now the patient is leaning on their drainage cannula, right? There's nothing wrong with the patient or their volume status. It's just that the drainage tubing is getting compressed by the weight of the patient, okay? So if you notice that, just reposition the patient, make sure there's nothing obstructing the drainage cannula, and if that fixes the problem and it doesn't come back, that was the issue. But let's just say, same situation, your flow is lower, and you have identified it as being a drainage issue. You come into the patient, you assess, there's nothing mechanically wrong with the circuit, the patient isn't leaning on anything, there's nothing obstructing the drainage. Go to your second bucket. The second bucket is that the patient is hypovolemic. So if they are hypovolemic or dry, don't forget your other skills just because you're on Ecmo. If someone's hypovolemic, their blood pressure is probably going to be lower, their heart rate's probably going to be higher, compensating. If you're measuring CDPs, it's probably going to be lower. Look at like your outputs, like is the patient peeing a lot, is their chest tube draining. So don't forget those skills just because you're on Ecmo. So if you think they're hypovolemic, what I would suggest is giving whatever your unit's bolus is, give half of it, okay? Give half the bolus to the patient, and I promise you, no matter what the problem is, this flow will go up, okay? And if it goes up and stays up and nothing happens again, that was the issue. You know, let's just say the CDP fell from 5, now it's back up to like 7 or 8. Your blood pressure came up, heart rate came back down, and your flow stays stable. Patient was hypovolemic, you fixed the problem. But let's just say you did it and it fixed the problem for about 5 minutes. Problem comes back again. I would then say give the other half of your bolus, and that again will fix the issue. And if it goes away, you know, the first bolus wasn't enough, second bolus was the right amount, and now you're flowing fine. But if you've given a whole bolus worth of volume and you still have the same problem, don't just keep giving volume, because you can actually make the situation worse. If the patient has enough volume and has a different problem, you're just going to overload that patient. So go to your third bucket. And that third bucket is that you have enough volume in the patient, but that volume can't get into the space where the cannula is, which would be the right atrium. So start thinking about like a cardiac tamponade. You have, you know, volume just sitting on the heart that's compressing the right atrium. So that volume that you have intravascular can't get into the right atrium. If you have like a pneumothorax where the intrathoracic pressure gets so high, it's compressing the right atrium. I've even seen people with like abdominal compartment syndromes pushing up into their chest, increasing their intrathoracic pressure, preventing their preload from getting to the pump. All right, all on the preload side of the pump. All right. The afterload side of the pump can also give you problems with flow. I can mimic only one of them because I can't get inside the oxygenator. But the first one I'll go over is what I can mimic. So if again you're flowing at 3,000 RPMs and your blood flow is 2.65, if I come in, and you'll notice, and before let me back up, let me go over what these pressures are. P1 or premembrane pressure is the pressure of the blood going into the oxygenator. P2 is the pressure of the blood leaving the oxygenator, and again measured by a normal transducer just after the oxygenator. The number in between is the delta P, or the difference in the pressure of it going in and coming out. The pressure going in always has to be higher because you need to have a higher driving pressure to get across and through the membrane. And the pressure coming out is always lower because there's always a pressure drop when you go across the membrane. And then each different oxygenator you use will have like a native pressure drop. The one that we use has a relatively low pressure drop, so your delta P when you first go on might be 10 to 20, the difference in pressure coming in and coming out. Other oxygenators might have a baseline of 50. But whatever your baseline is for that oxygenator, that's where your starting point is. All right. So remember, pressure going in, pressure going out of the oxygenator, and then the difference between the two. So with that in mind, we'll talk about the afterload. If I'm spinning at 3,000 RPM and my flow is 2.65 liters a minute, and then I come into the room, and now my flow is down almost a third again, right? And it touched the RPMs. Similar situation as the drainage side. The thing that's different is now my pressures went up. Before the drainage issues, these pressures went down. All right. So now that I know it's not a drainage issue and it's more of a return issue, I got to figure out what's going on. So if both the pressure going in and the pressure coming out of the oxygenator both go up at about the same rate, okay, meaning that your delta P didn't really change. Right before, the delta P was about like 5 or something, right, 4 or 5, and then when there's that obstruction, the flow went down, both pressures went up, but the difference stayed the same. That's indicative of some sort of obstruction of flow beyond the oxygenator. And that's because if you look where I put this clamp, it's after all the transducers, right? This is where the obstruction is. So that back pressure gets transmitted backwards to the postmembrane transducer through the membrane and to the premembrane transducer. So that's where it's transmitting all that pressure back. So like I said, that's indicative of some sort of obstruction of flow after the oxygenator. So you're going to troubleshoot again, just like you did in your drainage. The first thing I would do is the patient leaning on the return tubing now, not the drainage. If that's not the case, is there clot somewhere after the oxygenator that would cause an increase in resistance? If they're on VA Ecmo, the afterload that the pump is facing is SVR, right? Because you're going back into the arterial system. So if the patient blood pressure went up, you're going to see this happen. It might not be this dramatic, but you would see a drop in flow if the patient's blood pressure went up. But whenever you see both pre and post membrane pressures go up and your delta P stay relatively the same and a lower flow, think afterload. There's something resisting the flow going back into the patient. All right. And then if it's pre and post both going up, it's after the oxygenator. The other scenario I can't mimic because I can't get inside the oxygenator. All right. But if the pressure going into the oxygenator goes up by 50. So let's just say this was 200, now it's 250, and this stays the same. My delta P just increased by 50. So instead of being 5, it's 55. That's because there's some sort of obstruction inside the oxygenator. Because as the blood goes in, if the obstruction is inside, the transmission of higher pressure goes backwards to the premembrane, but there's nothing obstruction afterwards. So there's nothing to transmit backwards the pressure. So the pressure coming out of the oxygenator is going to be a little bit lower or the same. So when the premembrane pressure goes up and the postmembrane pressure stays the same and goes a little bit down, and the difference between those two numbers gets wider, obstruction of flow inside the oxygenator, 99% of the time it's clogged. So the basic question then is, do you need to change the oxygenator because it's clogged? And my answer is not a very good one because people don't like to hear it. It depends, right? My personal opinion is if the oxygenator is still functioning and the clot is on the premembrane side, there's no need to change the oxygenator, okay? Because there's inherent risk in changing the oxygenator. You know, every time you break into the circuit, it's like going into a central line and the risk of infection goes up. I can make a mistake. I can introduce air by accident, and then that air can get to the patient. Whenever you go onto an Ecmo circuit and you're exposed to all this plastic surface, your inflammatory response goes way up. Complement activation happens, and when you change out an oxygenator, the body has to get used to another foreign surface, and that process can start up again. So it's not benign to change out an oxygenator. So what reasons are there to change out the oxygenator? Let's just say my patient now, all of a sudden, their SATs are starting to dry out. I need to figure out, is the patient getting worse or is my oxygenator getting worse? So if my delta P is getting wider because the pressure going into the oxygenator is going up and the pressure coming out is staying the same or going lower. You have clots in the oxygenator and the patient's sats are going down. What I would do then is do a pre-membrane ABG and a post-membrane ABG. I remember how we talked about that gas exchange. If I'm at 100%, the PO2 roughly coming out should be 5 times that. If I'm at 100% and the PO2 coming out of the oxygenator is now 80 or 100, then the oxygenator is not working very well because it can't exchange that gas because all that clot in there. And if the patient is desatting, then this poorly functioning oxygenator is the cause of it. So then I would have to change out the oxygenator. But if the patient is not having any bad effects, if I'm expecting the PO2 to be 450 and it's 200, but that's all the patient needs because the patient's still satting fine and they're going to come off in a day or two, I wouldn't take the risk of changing it. But if it's the first day, you're going to be out for a week or two and it's not performing well, I would change it. Mm-hmm. To me, the biggest number on Ecmo is, especially if you're on VA Ecmo, is your SpO2, right? Because obviously your SpO2 is basically what's letting us know if you're meeting metabolic demand. So as your SpO2 starts to go down, we have to ask ourselves, how can we fix this? How can we deliver more oxygen to the patient? There's 2 ways of delivering more oxygen on Ecmo. You can increase your flow. So you're basically delivering, it's essentially increasing your cardiac output. So you're getting more hemoglobin and oxygen to the tissues at a faster rate. Or if your oxygen level is low, you can always give blood, right? So now you're giving more oxygen carrying capacity. And those 2 things are really what we can do to increase your oxygen delivery. On the demand side, what we can do a lot of times is sedate the patient, which will reduce their their metabolic demand. We can paralyze them, or on ECMO, we can cool them. So on the supply side, it's give blood, increase flow. On the demand side, it's sedate, paralyze, and cool.